Today we're gonna talk about approach to diagnosing abdominal pain. Abdominal pain is one of the most common reasons for outpatient and ER visits. Variation in the degree of pathology is vast, some of which needs immediate attention, and a lot can happen in the abdomen and you need an organized approach. Differential diagnosis. When evaluating a patient with acute abdominal pain, the physician should focus on common conditions that cause abdominal pain as well as on more serious conditions. The location of pain should drive the evaluation. For some diagnoses, such as appendicitis, the location of pain has a very strong predictive value. A final diagnosis is not usually made at the first outpatient visit, therefore, it is critical to begin the evaluation by ruling out serious conditions, for example, vascular diseases such as aortic dissection and mesenteric ischemia, and surgical conditions, for example, appendicitis and cholecystitis. Physicians should also consider conditions of the abdominal wall such as muscle strain or herpes zoster because these are often misdiagnosed. Differential diagnosis of abdominal pain according to pain location. In the right upper quadrant, the possible diagnosis may be biliary as cholecystitis, cholelithiasis and cholangitis, colonic as colitis and diverticulitis, hepatic as abscess, hepatitis and mass, pulmonary as pneumonia and embolus, renal as nephrolithiasis and pyelonephritis, biliary as cholecystitis, cholelithiasis and cholangitis, cardiac as myocardial infarction and pericarditis. If the pain is epigastric, the possible diagnosis may be gastric as esophagitis, gastritis and peptic ulcer, pancreatic as mass and pancreatitis, vascular as aortic dissection, mesenteric ischemia, cardiac as angina, myocardial infarction, and pericarditis, gastric as esophagitis, gastritis, and peptic ulcer. If the pain is in the left upper quadrant, it may be pancreatic mass, pancreatitis, renal nephrolithiasis, pyelonephritis, vascular aortic dissection, mesenteric ischemia, colonic early appendicitis. If the pain is para-umbilical or periumbilical pain, the possible diagnosis may be gastric as esophagitis, gastritis, peptic ulcer, small bowel mass or obstruction, vascular as aortic dissection, mesenteric ischemia, colonic as appendicitis, colitis, diverticulitis, IBD, and IBS. Right lower quadrant as gynecological ectopic pregnancy or fibroids, ovarian mass, torsion, or PID. Renal as nephrolithiasis and pyelonephritis. Colonic as appendicitis, colitis, diverticulitis, IBD, and IBS. Suprapubic gynecological reasons as ectopic pregnancy, fibroids, ovarian mass, torsion, PID. Renal as cystitis, nephrolithiasis, and pyelonephritis. Colonic as colitis, diverticulitis, IBD, and IBS. If the pain in the left lower quadrant, causes may be gynecological causes as ectopic pregnancy, fibroids, ovarian mass, torsion, and PID, renal as nephrolithiasis, pyelonephritis, abdominal wall as herpes zoster, muscle strain, and hernia. Any other location may be bowel obstruction, mesenteric ischemia, peritonitis, narcotic withdrawal, sickle cell crisis, porphyria, IBD, heavy metal poisoning. Although the location of abdominal pain guides the initial evaluation, associated signs and symptoms are predictive of certain causes of abdominal pain and can help narrow the differential diagnosis. Useful findings in the evaluation of abdominal pain. In appendicitis, there is right lower quadrant pain, migration of pain from the periumbilical area to the right lower quadrant of the abdomen, fever, suicide, rebound tenderness, rigidity, and anorexia. In bowel obstruction, there is constipation, abdominal distension, pain decreases after vomiting, colic, previous abdominal surgery. In the cholecystitis, there is Murphy's sign, right upper quadrant pain, fever, and jaundice. History taking. When possible, the history should be obtained from an unsedated patient. The initial differential diagnosis can be determined by a delineation of the patient's location, of the pain's location, radiation, and movement. For example, appendicitis-associated pain usually moves from the periumbilical area to the right lower quadrant of the abdomen. After the location is identified, the physician should obtain general information about onset, duration, severity, and quality of pain, and about exacerbating and remitting factors. Physical examination. The patient's general appearance and vital signs can help narrow the differential diagnosis. Patients with peritonitis tend to lie very still, whereas those with renal colic seem unable to stay still. Fever suggests infection, however, its absence does not rule it out, especially in patients who are older or immunocompromised. Tachycardia and orthostatic hypotension suggest hypovolemia. The location of pain guides the remainder of the physical examination. Physicians should pay close attention to the cardiac and lung examinations in patients with upper abdominal pain because they could suggest pneumonia or cardiac ischemia. There are several specialized maneuvers that evaluate for signs associated with causes of abdominal pain. When present, some signs are highly predictive of certain diseases. These include Carnet's sign, for example, increased pain when a supine patient tenses the abdominal wall by lifting the head and shoulders off the examination table. In patients with abdominal wall pain, Murphy's sign in patients with cholecystitis, although it's only present in 65% of adults with cholecystitis and is particularly unreliable in older patients, and the Suez sign in patients with appendicitis. Other signs such as rigidity and rebound tenderness are nonspecific. Rectal and pelvic examinations are recommended in patients with lower abdominal and pelvic pain. A rectal examination may reveal fecal impaction, a palpable mass, or ocal blood in the stool. Tenderness and fullness on the right side of the rectum suggest a retrocecal appendix. A pelvic examination may reveal vaginal discharge, which can indicate vaginitis. The presence of cervical motion tenderness and peritoneal signs increase the likelihood of ectopic pregnancy or other gynecological complications such as salpingitis or a tubo-ovarian abscess. Laboratory tests. Appropriate diagnostic testing varies based on the clinical situation. A complete blood count is appropriate if infection or blood loss is suspected. One study of patients 15 to 83 years of age with suspected appendicitis found that a white blood cell count greater than 10,000 per millimeter was 77% sensitive and 63% specific for the diagnosis. Thus, nearly 1 in 4 patients with appendicitis does not have an elevated white blood cell count. In patients with epigastric pain, simultaneous amylase and lipase measurements are recommended because an elevated lipase level with a normal amylase level is not likely to be caused by pancreatitis. Liver chemistries are important in patients with right upper quadrant pain. A urine analysis should be obtained in patients with hematuria, dysuria, or flank pain. A urine pregnancy test should be performed in women of childbearing age who have abdominal pain to narrow the differential diagnosis and to determine whether certain imaging studies are appropriate. Testing for chlamydia and gonorrhea is recommended for women at risk of sexually transmitted infections. Imaging studies. Recommendations for initial imaging studies are based on the location of the abdominal pain. Ultrasonography is recommended when a patient presents with right upper quadrant pain. Radionuclide imaging is slightly better than ultrasonography for detecting acute cholecystitis but is more expensive and takes longer time to perform and cannot assess diagnosis outside of the biliary tract. Recommended imaging studies based on location of the abdominal pain. If the location of the pain is in the right upper quadrant, imaging should be ultrasonography. Left upper quadrant, CT. Right lower quadrant, CT with IV contrast media. Left lower quadrant, CT with oral and IV contrast media. Suprapubic ultrasonography. Plain radiography of the abdomen is often more readily obtainable and less expensive than ultrasonography or CT and can be helpful in several circumstances. An upright radiograph of the chest or abdomen can detect free air under the diaphragm, which indicates a perforation of the gastrointestinal tract. Abnormal calcifications also can be seen on a plain radiograph. This includes 10% of gallstones, 90% of kidney stones, and appendicitis in 5% of patients with appendicitis. Plain radiography of the abdomen may help diagnose bowel obstruction with multiple dilated loops of the bowel and air fluid levels, although similar findings may occur with paralytic ileus. Women of childbearing age present a specific challenge when making decisions about diagnostic imaging. Gynecologic causes of abdominal pain are more common in these women, and radiation exposure should be avoided if pregnancy is likely. Therefore, abdominal or transvaginal ultrasonography is generally recommended for evaluating left lower quadrant pain in women with childbearing age and in pregnant patients with right lower quadrant abdominal pain. If ectopic pregnancy is suspected, transvaginal ultrasonography should be performed. Approach to patients. A stepwise approach to abdominal pain requires identification of specific high-risk populations. In low-risk patients, the pain location guides the initial differential diagnosis. Several areas of the abdomen deserve special attention because the clearest evidence for a consistent workup is in these areas. For right upper quadrant pain, the history focuses on differentiating pulmonary, urinary, and hepatobiliary pain. If urinary tract infection or nephrolithiasis is suspected, urine analysis is appropriate. Patients with colic, fever, steatorrhea, or a positive Murphy's sign should receive ultrasonography. To sum it up, acute abdominal pain can represent a spectrum of conditions from benign and self-limited disease to surgical emergencies. Evaluating abdominal pain requires an approach that relies on the likelihood of the disease, patient history, physical examination, laboratory tests, and imaging studies. The location of pain is a useful starting point and will guide further evaluation. For example, right lower quadrant pain strongly suggests appendicitis. Certain elements of the history and physical examination are helpful. For example, constipation and abdominal distension strongly suggest bowel obstruction, whereas others are of little value. For example, anorexia has little predictive value for appendicitis. The American College of Radiology has recommended different imaging studies for assessing abdominal pain based on pain location. Ultrasonography is recommended to assess the right upper quadrant pain, and computed tomography is recommended for right and left lower quadrant pain. It's also important to consider special populations such as women who are at risk of genitourinary disease, which may cause abdominal pain, and the elderly who may present with atypical symptoms of a disease. Abdominal pain is a common presentation in the outpatient setting and is challenging to diagnose. Abdominal pain is the presenting complaint in 1.5% of office based visits and in 5% of emergency department visits. Although most abdominal pain is benign, as many as 10% of patients in the emergency department setting and a lesser percentage in the outpatient setting have a severe or life threatening cause or require surgery. Therefore, a thorough and logical approach to the diagnosis of abdominal pain is necessary. Thank you.